Hello, my name is Mei Kwong, the Executive Director at the Center for Connected Health Policy, and today I'll be talking to you about the California telehealth policy proposals for Medi-Cal. This video is dated March 23rd of 2021, so please keep that date in mind as these are just proposals at the moment. They can change, they may not be accepted, or they may be accepted at a later date. A few disclaimers before we get started. Please know that any information provided today is strictly for informational purposes. It is not to be considered legal advice. If you are interested in a formal legal opinion, please consult with legal counsel. Also know that CCHP has no relevant financial interest, arrangement, or affiliation or relationship if I happen to mention a company or show some type of product. A little bit of background about CCHP. We were established as the California Telehealth Policy Organization in 2009 underneath the Public Health Institute. However, we became the federally designated National Telehealth Policy Resource Center through a grant from HRSA in 2012, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal levels on other projects related to telehealth or connected health. And we're also the administrator for the National Consortium of Telehealth Resource Centers. We also convene a group in California called the California Telehealth Policy Coalition, which is a coalition of over 100 statewide groups and individuals who are interested in advancing telehealth policy in the state. A little bit of background about the National Consortiums of Telehealth Resource Centers. This is made up of the 14 telehealth resource centers who are underneath the same program as CCHP with HRSA. There are 12 regional resource centers that cover specific states. And then there are 2 national resource centers, one on policy, which is CCHP, and one on technology. All 14 telehealth resource centers work very collaboratively together underneath the umbrella of the National Consortium. So I like to say if you reach out to one telehealth resource center, you're really getting all 14 of us trying to address your issue. As many of you know, COVID-19 really changed the landscape, not only in how we receive healthcare services, but for telehealth specifically. So what happened on both the federal and the state level were massive changes, at least temporarily, to their telehealth policies. And you see a lot of commonalities on where those policy changes happened, such as location of the patient, what modality was allowed to be used to deliver the services covered, and the types of providers who could provide the services. A lot of states and the federal government right now are really examining what of these temporary policies are they going to make permanent, and California is no exception. So California pre-COVID-19 telehealth policies in their Medicaid program were actually pretty expansive. It was one of the most progressive telehealth policies out there before the pandemic hit. What it basically did was it allowed providers to basically select what modality they can use out of store and forward or live video to deliver the service. And the service would be covered by the Medi-Cal program if it was a service that they would typically cover, if it was delivered in person, and also if the service did not have some sort of requirement where an in-person requirement was involved or where technology could not be used to deliver that service. There were also really no limitations on the location of the patient, so the home was an eligible originating site. And as far as what providers could be allowed to deliver the service and still be covered and reimbursed, basically it was any Medi-Cal provider as long as they were operating within their scope. There were some limitations. So there were limitations on what FQHCs and RHCs could do with telehealth, but they were allowed some leeway. So for example, FQHCs and RHCs had a little bit of ability to provide services via store and forward, such as dermatology and ophthalmology. Additionally, in California, before the pandemic, there was a requirement for oral written consent before telehealth was used. And also a bill had just been passed that impacted commercial payers, AB 744, that would require them to cover telehealth delivered services at parity, both in payment and in coverage. However, that bill would not have kicked in until January 1st of 2021. So when the pandemic hit, California was in a fairly good place as far as their telehealth policies. So the temporary changes that the state had to make around the Medicaid program were actually pretty minimal if you compared them to what other state Medicaid programs had to do. Pandemic hits, again, there were some areas in which the Medicaid program did have to make some changes, some temporary changes. One of the big ones was allowing FQHCs more flexibility to use telehealth. So some of those limitations I mentioned earlier were removed. So FQHCs were able to basically have the same ability and flexibilities on location. Before the pandemic, FQHCs were very limited in where they could provide services, where the patient could be located when services were provided. For example, pre-pandemic, FQHCs and RHCs could not provide services when the patient was at home unless they were homeless, migrant, or seasonal workers. That restriction was lifted during the pandemic, which makes total sense because of the pandemic. Most people were sheltering in place at home. Additionally, a change was made to the modality. So like the Medicare program and other states, California allowed the use of audio-only phone to deliver services during the pandemic. Pre-pandemic, many places did not consider audio-only phone to be underneath the umbrella of telehealth, but however, policymakers recognizing not everybody would have access to live video allowed audio-only phone to be delivered or used to be delivered some services. In California, Medicaid program was no different. They allowed that to be used. They were actually a little bit more expansive. They did not have as many limitations on what services audio only could be used as other Medicaid programs did. So for commercial plans, the state essentially moved up that AB 744 date from January 1st of 2021 to during the pandemic, asking plans to please cover telehealth delivered services the same way they would have in person. They also relaxed some of the privacy laws or some of the privacy requirements, allowing texting to be used to a certain extent to deliver services. And there was a little bit of relaxation of licensing in that they would allow out-of-state providers to provide services within California without having to get a California license, which was what was required pre-pandemic. If there was a facility in California that put in an application with the California Emergency Services Administration saying, I want this particular provider to provide services within my facility. So it was a little bit of relaxation of licensing, but not an expansive relaxation. There was still an administrative requirement that you would have to have a facility basically apply for you to allow that exemption there. But overall, California did relax some of its requirements, definitely around in the Medicaid program. There were issues that were raised that California did see during the pandemic as well. And I think this was probably common for a lot of jurisdictions, not just for California. Obviously, the big one was broadband. Again, why you needed audio-only phone to be allowed during the pandemic is because not everybody had connectivity. And without that connectivity, telehealth does not work. So broadband has definitely been an issue both on the federal and the state level that's been heavily discussed and looked as being, a significant issue. Licensure, I talked a little bit about what California allowed, but that's also been sort of more of a higher profile and heightened discussion during the pandemic because you had many people who were essentially stuck because of travel bans or, shelter in place requirements where they were still trying to access services from the regular provider, but maybe they were located in a different state. Privacy and security issues. Again, I mentioned that there was some relaxation of that, both on the federal and the state level of those probably will be something that will be rolled back to pre-pandemic levels and very little changes might be made to them, at least initially, but the discussion is there now of what of these privacy and security measures might we want to look at just to update them to accommodate the use of technology now to deliver healthcare services. And then a couple other things that surfaced during the pandemic that maybe were regarded as issues is outdated forms and mechanisms. Again, because you have these expansive telehealth policies, you may not have mechanisms in place, something as simple as a form that has a spot to make a notation that you did the service via telehealth that you can submit. You may not have been a facility or a provider who typically had that on your form. So suddenly you pivoted to telehealth, provide telehealth services because the policies allow you to do that. Your typical form may not have been updated that quickly. So that was something that we actually did encounter and get questions on during the pandemic. And then education of providers and patients. So a lot of providers probably were familiar with telehealth, or at least the concept, though they may not have actually utilized it to provide services themselves. So they did require some education on that. But definitely patients were not familiar with the modality or receiving healthcare services that way. So there really was an education gap there, definitely for consumers and patients regarding telehealth that wasn't systematically filled in. What you probably had happen was just really the providers educating the patients. And if you were a provider who was new to telehealth yourself, you may not have had the tools readily available to you, like the information to like, simply hand to your patients. So there was sort of like a bit of haphazardness, I guess, involved, unequal sort of like education of patients because people were just trying to figure it out on their own. There wasn't like a consistent sort of resource that you could go to aside from maybe the telehealth resource centers who try to provide that information to providers, but probably not all providers went through the telehealth resource centers for that information. So again, you had them trying to create their own types of educational materials for their patients. So these were some of the issues that were sort of brought to the surface or like, bubbled up even more during the pandemic. So what are the 2021 proposals? What is California looking at to make permanent? So there's actually two channels in which to do that. So you can go a legislative route and an administrative route. And for today's talk, I'm just talking about the administrative route. There are bills in California currently with the California legislature of looking at some of these temporary proposals and making them permanent. But we're going to focus in on what the administration has said. So in California, typically the governor comes out with a January budget proposal for the next fiscal year. And in that proposal, they may contain some recommendations on, what to do with the Medi-Cal program. The Medicaid program in California is called Medi-Cal. For those who don't know, that's why I say Medi-Cal. The Medi-Cal program, and there were regarding telehealth, some proposals on what he is thinking, the administration is thinking of making permanent in the Medi-Cal program as far as telehealth policies. So when the governor came out with her January proposals, there was some vague mention of that there was a review being done by the Department of Healthcare Services, which runs the Medicaid program here in California, and that they were doing a global review of their telehealth policies and would be issuing a report that would contain their own recommendations. And that governor referenced that in his January budget proposal. He also referenced that California Medicaid would start covering remote patient monitoring, which was one area that they did not have before the pandemic. So details, though, were few in the January proposal, and also the report by Department of Healthcare Services had not been released yet when the governor's budget came out. So people in California were just kind of waiting to see what happened. In February, the Department of Healthcare Services did release a report with a recommendation, and also the governor's budget bill. What they usually have to like sort of flesh out the proposals are trailer bills. So the trailer bill language for this particular for telehealth policy also was issued around the same time. So we're going to look at what the proposed changes are for both that were both in the trailer bill language and also Department of Healthcare Services report and recommendations. And just very overview, this is what it kind of looks like. This has your pre-COVID, your COVID, and your proposals that were made. And this is not all the proposals. I just picked out a couple of ones to like line them up with like where these other policies were during pre-COVID and during COVID as well. And as you can see, they're addressing each of these in some way in the proposals, either in the trailer bill language or in the recommended report from Department of Healthcare Services. So for Synchronous and live video, basically they are recommending parity both in their managed care and fee-for-service. Now, California Medicaid program is both of them. There's a portion of it that's fee-for-service and the other portion is managed care. So they're recommending parity for coverage of services and payment in both the managed care side and fee-for-services. They're saying that providers, including FQHCs and RHCs, are allowed to use live video. So that basically was essentially the same as what we had pre-pandemic. They're also giving a little bit more flexibility to the FQHCs and RHCs, saying they can establish a new patient relationship when they're using live video as well, as long as the patient is within their federal designated area. So it's not saying for any patient in the state, but basically if they're within their area, you can use telehealth, synchronous telehealth live video to establish a patient-provider relationship. There were also during the pandemic some relaxations that they allow for specific programs such as targeted case management and LEA billing option program, LEA BOP. So they're allowing that to remain as well as well as the state drug Medi-Cal program. Now, the big changes are what happens to the other modalities. As I mentioned at the beginning of the talk, pre-pandemic, asynchronous and live video, as far as the Medicaid program was concerned, was essentially treated the same. The provider could decide whether they were going to deliver services asynchronously or live video based upon their own judgment. And that option was open to them. FQHCs and RHCs had a more limited use of asynchronous. The proposals that are being made is that asynchronous and audio only phone would essentially be put into this other bucket, this other stream separate from live video, and it would have its own policies, its own fee schedule, its own sort of what they termed utilization management. And I'm not quite sure what that term means because it wasn't defined anywhere. But to me, that says probably like limited amounts. So probably like a cap of maybe, two visits a week or something like that if it's done via store forward, something like that. But that's only a guess on my part. As I said, it wasn't defined. But it's separate, but these modalities and remote patient monitoring was also included in here in this bucket are separated from live video. It would have their own separate policies, their own separate reimbursement fee schedule, and so forth. And the reasoning behind this from the Department of Healthcare Services is saying that these aren't on the same level as live video. Live video is very similar to like in person. So, but these things are something completely different. So they should have these different policies. They should be reimbursed differently as well. Also, these other modalities would not be available to FQHCs and RHCs to use as well. So as I mentioned earlier, pre-pandemic, FQHCs and RHCs had limited use of asynchronous, but it was still there. They would not get that if these proposals were to move forward and be adopted intact. Other proposed changes, one of the sort of more expansion things was that they limited the site limitations for FQHCs and RHCs as long as it's within their federally designated area. So that was, again, sort of an expansion that they're allowing FQHCs and RHCs doing. And then for network adequacy, the Department of Healthcare Services could authorize a Medi-Cal managed care plan to use clinically appropriate synchronous interactions to meet time or distance standards to meet network adequacy. So that was also offered as well as a proposal too. This is just sort of like, again, a little sampling of some of like the highlights and the impact. But what we're essentially seeing with the separating out of the live video from the other modalities is very similar to like what we see on Medicare. Now, for those who don't know, Medicare obviously has their own telehealth policies, but Medicare has an approach, two different approaches to the technology. They have their telehealth approach and they have their communications technology-based services approach. Telehealth approach is telehealth technologies that are used to replace in-person services. And their policies are very limited. These are all the policies that are embedded in federal statute that basically say it needs to take place in a rural area. It's only these providers can provide their services, etc. That's Medicare's telehealth policies, very focused on live video. But also it's that way because they're restricted by what's in federal law as well. Then Medicare also has this other bucket of communications technology-based services where they say, like, you can provide these services through telehealth technologies, but we don't consider them telehealth because they're not replacing an in-person service. These are services that we typically would not give in person, but because technology allows us to do this, we can deliver these services. So we're calling them communications technology-based services, not telehealth. So they're not held to those restrictions that telehealth are, those statutory restrictions, but they use telehealth technologies. And in this bucket, they allow remote patient monitoring, they allow store and forward to be used, live video is in there as well, so is audio only phone. So as you can see here, that's why I'm saying that there's a lot of similarities for what California is proposing, as there is with Medicare, in that you have like a live video channel and you have like basically all the other modalities, and they have their separate policies around them, their separate fee schedules. Do not know if that was intentional or not, but it looks very similar to me. So what does this all mean if those proposals go through intact? This is just a visual here. So we have our pre-COVID policies, which is the blue circle, and our COVID policies were definitely more expansive and it encompassed all those pre-COVID policies. And then you have your proposals, which are in red. It takes some from each of those and then offers something new. But in some ways, it really moves California back in some of the policy areas, especially around asynchronous and storm for asynchronous/storm forward, to something that was a little bit, not as forward thinking as we had before the pandemic. Now, again, this video is being recorded on March 23rd, 2021. So right now, these proposals are exactly that. They are just proposals. So they haven't been fully discussed or examined. They could be changed. They could be discarded. We could have something completely new. But I just wanted to give folks out there, a bit of information of what's being discussed in California, because California does sometimes have influences in other states and other areas around policy as well. So it'll be really important to keep an eye on what's going on in California, especially since before the pandemic, it had one of the most progressive, expansive telehealth policies in their Medicaid program before. So I would just offer that you stay tuned to CCHP's website, subscribe to our newsletter, keep an eye on our website and for any updates and information. And just thank you for listening to this video. And I hope you stay safe and have a great day.